two beautiful countries in the world, India and Australia. This is eCritCare podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checo from India.
Welcome to eCritCare podcast. This is our episode number 110, and I'm joined by my co-host, Dr. Jose Checo. Welcome, Dr. Checo.
Hi, Swapnil. Good evening.
Good evening. So, Dr. Checo, it has been quite exciting times as we are getting ready for publishing the book called as Critical Care Controversies. Can you tell us a little bit more about the book?
Well, it is a updated book on burning topics in critical care that you come across every day in your practice, ranging from how do you titrate PEEP to how do you feed your patients. So it's a whole range of controversial issues for which ready answers are not really available. And we have looked at the most updated evidence and come up with 50 plus controversies and updated the evidence on these controversial topics. So it'll be a good resource, not only for trainees in critical care, but also for practitioners in critical care medicine to look at these controversies which they encounter in everyday practice, and they can come across a balanced view, we hope, through our book.
It has been quite a fascinating journey, and being a part of this journey was quite rewarding experience, and I'm pretty sure the readers will feel the same way. And the Kindle edition will be published next week, and the paper print or the hard copy will be available in first or second week of May. So stay tuned, look for critical care controversies, and obviously we will post the updates on social media as they are available. Let's dive into today's topic, which is another interesting controversy about using high flow nasal cannulae versus non-invasive ventilation as a routine post-extubation practice in order to kind of avoid extubation failure. So this trial, which was published in Intensive Care Medicine, comes from Spain, and it's not really kind of controversy as such for me, but having said that, the practices across the globe have been quite variable along this matter. Some people like to extubate preemptively their patients onto NIV to avoid extubation failure. Since we have now another resource available in the form of high-flow nasal cannulae, the use of high-flow nasal cannulae has definitely gone up significantly in recent times. Having said that, the robust evidence in favor of any of those devices to use as a routine practice, especially in the high-risk patients, has been quite controversial. Now, how do you find out the patients who are at risk of extubation failure? Again, there is no strict criteria or guidelines, but having said that, there is some guidance around what are the kind of key factors that might suggest that this patient is at risk of extubation failure. And that these factors include age, prolonged mechanical ventilation for at least more than a week or two, Apache score at admission more than 20 if you're going with Apache 2 score, difficult weaning for patient who had already failed extubation in the past, obesity with BMI of around more than 30, the presence of comorbidities, occurrence of hypercapnia at the end of spontaneous breathing trial if you are practicing one at place, airway patency problems, difficulties in managing respiratory secretions, and acute or chronic heart failure, along with COPD. And these different factors, obviously, if you add or combine those factors in one particular patient, obviously the risk of extubation failure or chance of extubation failure are going to be quite high. There has been a previous trial by same authors in 2016, which suggested the non-inferiority of high-flow nasal cannulae to NIV in terms of post-extubation success. And that was done in relatively low-risk population. So in this particular trial, authors decided to test both strategies in patients who have number of risk factors, particularly more than or equal to 4 risk factors. And the hypothesis was these patients with higher risk factors will respond better to NIV compared to high-flow nasal prong. So The hypothesis of this trial was the prolonged use of NIV with active humidification is superior to high flow nasal cannulae in specific population of patients with more than or equal to 4 high risk factors for extubation failure. So, Dr. Chacko, can you please walk us through the methodology and the results of the trial, please?
It is a study by Hernandez et al. It's the same group of investigators which published the JAMA paper of 2016. So they conducted this study, this randomized controlled trial from 2 ICUs in Spain, and they were up to evaluating the efficacy of NIV with active humidification. Usually we use NIV without any active humidification, but they used NIV with a humidifier device and compared it with high flow nasal cannula on reintubation rates in adult patients who received mechanical ventilation for 24 hours or more and who are at high risk of extubation failure. And to identify patients at high risk of extubation failure, they had 10 criteria, out of which if a patient met 4 or more, they considered it high risk. And the criteria were elderly, age more than 65, patients on ventilation for 7 or more days, or hypercapnia of more than 45 millimeters of mercury. Mechanical ventilation was required primarily for cardiac failure, moderate to severe COPD, Apache 2 score of more than 12 on the day of extubation, obese patients with a body mass index of more than 30, problems expected with airway maintenance, poor cough reflux, prolonged or difficult weaning with 1 or more episodes of weaning failure, and the presence of 2 or more comorbidities. So these were the 10 risk factors they identified. And if a patient met 4 or more of these, then they were categorized as at high risk of extubation failure. They excluded patients who were not for resuscitation or who had contraindications for an IV use, among them being recent surgery of head and neck, active upper GI bleed, excessive secretions. So they were excluded. How did they do it? They tried to wean their patients with a daily screening for evaluation for readiness of weaning. Those who were considered ready underwent a spontaneous breathing trial with a pressure support of 7 and 0 PEEP. They did not use PEEP, so just 7 of pressure support for a period of 30 minutes. And those who tolerated this spontaneous breathing trial were put back on full ventilator support for 1 hour. Now, this is a practice that many ICUs do. In fact, there is a study also that supported the practice of putting them back to full support prior to extubation. This is to enable a period of rest prior to extubation, and of course, evaluate the patient further if it is appropriate. So here again, the authors, after pressure support of 7 for 30 minutes as a spontaneous breathing trial, put the patients back on their full ventilator support for 1 hour, and then extubated them. And then once they extubated these patients, they were divided into 2 groups. One of the groups, of course, was NIV with active humidification, in which NIV was initiated using a heated humidifier. The inspiratory and expiratory pressures were variable, and they were set to deliver a tidal volume of 6 to 8 mils per kilogram and to maintain a respiratory rate of less than 26 per minute, saturation of more than 92%, and a pH of 7.35 or thereabouts. So that was the patients who were randomized to NIV with active humidification. In those who were randomized to the high flow nasal cannula group, they were applied, the nasal cannula were applied just prior to extubation. The initial flow rate was set at 10 liters per minute and increased in steps of 5 liters per minute to a maximum flow of 60 liters per minute, depending on the patient comfort level. And the temperature set was initially at 37 degrees centigrade. Patients in both groups had their FiO2 titrated to a saturation level of more than 92%. Both the modalities of support were continued for a duration of approximately 48 hours, after which they were switched to conventional oxygen therapy as required. Rescue NIV was not allowed in the high flow nasal cannula group. Other aspects of care were left to the clinician's judgment. Reintubation was based on predefined criteria. The authors calculated a sample size based on the primary outcome of reintubation within 7 days of extubation. And they assumed a 45% reintubation rate at baseline. And the sample size they calculated was 88 patients in each arm, which would provide a power of 80% at an alpha level of 0.05 for an absolute reduction in the reintubation rate by 21%. So this is how they set about performing this study. And what did they find? They randomized 182 patients. This was, of course, the sample size, approximately the sample size that they calculated. 92 patients received humidified NIV and 90 received high-flow nasal cannula. Patients with acute heart failure, COPD, and hypercapnia at the end of the spontaneous breathing trial were more in the NIV group. So the primary outcome was reintubation due to any cause at 7 days. The reintubation rate at 7 days was significantly lower with humidified NIV compared to high-flow nasal cannula, 23.3% versus 38.8%, for an absolute risk difference of minus 15.5, p-value of 0.019, statistically significant in favor of NIV with humidified gases. The number of patients who needed to be treated with NIV to avoid one reintubation was 6.2 patients. So if you treated 6.2 patients with NIV, you would save one patient from getting reintubated. Among patients with risk factors known to benefit with NIV, including acute heart failure, COPD, and hypercapnia at the end of the spontaneous breathing trial. So among these patients with known risk factors which have been found to benefit NIV, as expected, reintubation rates were indeed lower with NIV compared to HFNC. They looked at several secondary outcomes as well. The median time to reintubation was almost identical in both groups at 27 hours. The incidence of post-extubation respiratory failure was defined or was predefined, and the incidence was similar in the NIV and high-flow nasal cannula groups, 43.5% with NIV, 44.4% with HFNC. Surprisingly, ICU mortality and hospital mortality were higher with NIV, although the difference was not statistically significant. In fact, the ICU mortality was 13% in the NIV with humidification group compared to 4.4% in the HFNC group. Hospital mortality was correspondingly 15.2% versus 6.7%. The median length of ICU stay was, however, shorter with NIV compared with high-flow nasal cannula, 9.5 versus 12.5. The hospital length of stay also shorter with NIV compared to HFNC, but the difference was not statistically significant. Discomfort associated with therapy was more common with NIV, including nasal discomfort, skin ulceration, and on occasions, this necessitated temporary discontinuation of therapy. So that's pretty much as expected. NIV was more uncomfortable compared to high-flow nasal cannula. They looked at a few exploratory outcomes as well, and the findings were all the reintubations in the NIV group occurred within the first 5 days. After 5 days, only patients in the HFNC group were reintubated. The reintubation rates at the end of 3 days and 5 days were similar in both groups. The time to reintubation was significantly longer with high-flow nasal cannula in patients who were reintubated within 5 days, and reintubation was associated with increased mortality. So this study aimed to evaluate the efficacy of NIV with active humidification compared to HFNC in preventing reintubation in adult patients who were at high risk of extubation failure. And they found that reintubation rates due to any cause at 7 days were significantly lower in the humidified NIV group compared to the HFNC group, with one patient being saved of reintubation out of 6.2 treated with NIV. And patients with risk factors known to benefit with NIV, reintubation rates were lower with NIV compared to high flow nasal cannula. So they found that NIV with active humidification was more effective than high flow nasal cannula in preventing reintubation among high risk patients.
Thanks, Dr. Jaco. So I guess the results are not that surprising for me because it's obviously done in a very high risk population. And we all know that these patients are prone for extubation failure. And NIV usually works better to optimize these patients more. And this trial, I guess, confirms that findings or hypothesis. It's kind of interesting trial to start with. Just focusing on first the consort diagram, they screened 2,356 patients. Out of that, many patients were excluded, and finally they included only 182 patients after going through all the inclusion-exclusion criteria. Some of the strengths of this trial, obviously, this is one of the largest randomized controlled trial on this topic. The both groups are well matched at the baseline, and all the patients completed follow-up in both arms, which is quite great achievement. And coming back to the results, as you summarize in a nutshell, NIV is obviously more beneficial in terms of avoiding reintubations, but high flow nasal cannulae are probably more responsible for increased reintubation rates. Now, the reintubation rates that were found in this trial are beyond imagination, and they are quite high, 38% in high flow nasal cannula group and something around 22% in NIV group. Now, if you're a hospital administrator and if your ICU is performing at that level where you got 38% reintubation rates, I think you and your unit will be in trouble with that kind of KPI. So clearly, patients who are quite sick, they got more risk factors. Clearly, high flow is not a way to go. In terms of the limitations of the trial, yes, this trial was unblinded. It was a very small study and probably would have benefited by including more multinational sites in this trial to improve the external validity of the trial. Internal validity of the trial is good. There's no loss to follow up. Most of the patients, like all the patients, were studied with the intention to treat analysis. So all those things are reasonable. But statistically, I think this trial is quite interesting to analyze because on one side, it did show reintubation failure is less with NIV, but at the same time, as you mentioned, ICU mortality and overall length of stay in hospital or ICU is more with NIV compared to high flow nasal cannulae. So that's the kind of concerning result for me, although one can argue that the trial was not powered to test those outcomes and that there could be a chance than actual signal there. And I completely understand that part. But even if that signal is a bit hard to ignore if high flow nasal cannulae are going to cause more mortality and hospital length of stay. So I guess whether it will change my practice, I don't think so. At the moment, I extubate only when patient is stable enough and basically currently not on any enormous or industrial doses of any inotropic or vasopressor support or oxygen requirements are less than 40% throughout the last 24 hours. And then obviously it's quite safe to extubate them. And I guess which device you use is probably going to be based on what's the patient's tolerance to these units or devices, because some of the devices can be quite difficult for patient to tolerate. And I think in that case, overall failure rates are going to be even higher. So that's my kind of take on this trial. What's your thoughts, Dr. Jaco?
So in my mind, this study just confirms that in patients who are at high risk of reintubation, obviously NIV would certainly be beneficial or more beneficial compared with high flow nasal cannula. And this particular study had listed 10 risk factors, and among them were patients with moderate to severe COPD, body mass index of more than 30, those with poor cough reflex, patients who had failed weaning previously. So in this subgroup of patients, there is not much doubt that NIV with positive pressure support would probably be helpful. It is not a practice-changing trial as such. It just confirms whatever we knew previously and whatever is widely practiced as well, I believe, by most clinicians. High-flow nasal cannula has its own role, of course, but among patients like this, for instance, with COPD, hypercapnia, and so on, it'll obviously be preferable to use NIV. The second point that I would raise is the 45% reintubation rate that they use to calculate sample size. That is pretty high, as you suggested as well, which essentially means 1 in 2 patients is at risk of getting reintubated. So that's a pretty high number. And when you choose such a high number, the problem is that the sample size becomes too small. And if you look at the JAMA paper of the same group published more than 7 years ago, that sample size was actually 300 patients, 150 in each group. So 88 per group was what they had calculated for this particular study. It may have been underpowered as well. And of course, there were some findings in regard to mortality, which suggested that mortality is at least numerically higher with NIV, but the numbers are too small to take it with any kind of robustness. So this study essentially reinforces what is already known. Patients who are at high risk would definitely do better with positive pressure support using NIV rather than high-flow nasal cannula. But one of the things that I would like to introduce into our practice is the use of humidification with NIV. We don't normally use active humidification with non-invasive ventilation, but that's something we could try. And in this study, they used a mean temperature of 29 degrees centigrade as the target temperature in the humidified NIV group. We will be very interested to see what kind of temperatures will be tolerable among our patients as well, using humidifiers in which you can titrate the temperature of the inspired gas. So that's something worth looking at. And according to the authors, humidified NIV is likely to improve the comfort level and allow more prolonged use, resulting in a possible sustained effect compared to short periods of NIV use with prolonged breaks in between purely out of patient discomfort. So that's something which one could possibly look at.
Yeah, that's correct. So I guess I just mentioned probably there is a place for both interventions in our routine practice. It comes down to personalized medicine or individualized case selection and interventions in order to match them properly. And then obviously the benefit will be amplified. But if you're going to use the one intervention as a basket treatment with all patients, then clearly the value of interventions will go down. So you just need to use common sense approach. And obviously, if you're feeling that this patient has got a lot of high risk factors, is very at high risk of failure, I think we still suggest the first choice should be NIV. And then for patients who come with some refractures, overnight monitoring, had a post-cardiac surgery, in those kind of subset, high-flow nasal cannula will be better. So that's the end of our today's podcast. We'll be back in fortnight's time with another episode. Till then, goodbye and have a nice time.
Thanks, Swapnil. Thanks, everyone, for listening. And we will meet again next time in a couple of weeks' time.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.